RT is a 38-year-old female who visited her primary care physician for evaluation of frequent headaches. She began experiencing headaches at the age of 20, which she described as intermittent, moderately severe, throbbing headaches that lasted 1 to 2 days and were associated with nausea and light sensitivity. The headaches will usually begin 1 day prior to the onset of menstrual bleeding. She was able to treat them with over-the-counter analgesics such as the combination of aspirin, acetaminophen, and caffeine. These headaches began to occur at other times during the month and increased in frequency over the next 10 years. While the headache still responded to the OTC combination, she gradually had to increase her use of the medication. At times, when she had an important family or work obligation, she would take the medication to prevent a bad headache from occurring. By her early 30s, Artie occasionally missed work due to headaches. Though she previously was a very sound sleeper, her sleep pattern gradually became more disrupted. She would often wake up early in the morning with a bad headache. She also began to notice that it was taking more medication to achieve the same level of pain relief. The patient showed a classic presentation of medication overuse headache, which refers to headaches that are thought to be induced by use of abortive migraine medications such as painkillers or analgesics too frequently, which is consistent with the patient's history. MOH follows specific criteria depending on what type of abortive migraine medications are used. In this case, it's a combination type of medication, so it requires 10 or more days to be considered as an MOH pattern. The concern is that since the patient is in this MOH pattern, it's a risk factor for having migraine increase over time. That's why the patient went to transitioning from what's called episodic migraine to chronic migraine through the years. Medication overuse headache. Prevalence. Medication overuse headache has a prevalence of around 1 to 2% in the general population and should be suspected in anyone presenting with chronic headache, which is headache more than 14 days per month. Chronic headache is detrimental to one's health, causing significant reductions in quality of life and workplace productivity. Risk factors. MOH is more common to women than in men with a ratio of 1 is to 3 to 4. Prevalence is highest in the fourth decade of life. Other risk factors include family history, smoking, sleep disturbances, high body mass index, sedentary lifestyle, low socioeconomic status, pre-existing primary headache, pre-existing migraine, medication overuse, chronic musculoskeletal and gastrointestinal complaints, depression, and anxiety. Pathophysiology. Chronic headache caused by medication requires pre-existing headache. Other factors aside from medication includes psychosocial and socioeconomic. Sensitization of both peripheral and nociceptive pathways, polymorphism in genes associated with MOH, such as angiotensin converting enzyme, brain-derived neurotrophic factor, catechol all-methyltransferase, and serotonin transporter. When researchers applied DSM-4 to MOH patients, they found that two-thirds fulfilled the criteria for dependence. During a 12-month period, three or more of the following caused clinical significant impairment or distress: tolerance, withdrawal, taking larger amounts or over a longer period, persistent desire or unsuccessful efforts to reduce drug use, more time spent trying to obtain, use, or recover from its effects, giving up or reduced activities because of substance abuse, continued use despite knowledge of consequences. Diagnostics. To consider in patients with following: reports frequent headaches, especially with previous history of migraine, use of relief medication on more or less regular basis. We include neurological exam, which is recommended and should be normal. Headache diary, which includes detailed information on medication use for a minimum of 4 weeks, and imaging, only when suspicion of secondary headache. Diagnostic criteria. Each of the criteria from A to C needs to be filled for the diagnosis. First, headache on greater than equal to 15 days per month in a patient with a pre-existing headache disorder. Next, regular overuse of acute and/or symptomatic headache drugs for more than 3 months. Example, ergotamines, opioids, triptans, or combination of analgesics on greater than or equal to 10 days per month, simple analgesics for greater than or equal to 15 days per month, and any combination of the above mentioned or one or more medications other than those mentioned on greater than equal to 10 days per month. The headache cannot be better accounted for by another ICHT3 diagnosis. Treatment. When deciding how to treat the patients, we may find it useful to categorize patients into two groups, and these are uncomplicated and complicated. When we say uncomplicated, it is also known as type 1, meaning there's no behavioral impairment and no overuse of barbiturates or opioids. When we say complicated, it is also known as type 2. There is a significant psychological issues and or overuse of barbiturates and or opioid. MOH treatment involves four steps: 100% weaning off overused medications, establishing preventive medication and or behavioral or non-drug preventive strategies, providing acute medications with limits to prevent further overuse, and educating patients and families. Patient is evaluated based on duration and severity of headache attacks, number of overused medications consumed and their doses, comorbid medical and psychiatric conditions. Stepwise approach. Success in treating MOH should rely not only on applying clear and evidence based procedures, but in our opinion, also on performing the art of medicine. So, first, we correct diagnosis based on criteria and exclusion of other causes. And then we gather thorough information, and then we begin abrupt withdrawal with or without rescue medicine. Next is the evaluation on who should receive the prophylaxis. And shortly before the end, follow up. This is to avoid relapse, and also here we give advices. A portion of patients who stop taking analgesics will experience substantial improvement in the severity and frequency of their headache. Some patients may still continue to have headache, though they may feel clinically improved somehow. These residual symptoms probably represent underlying primary headache disorder. Drug withdrawal is a treatment of choice. 50 to 70% of patients respond well. No withdrawal regime seems to be superior. European guidelines from 2011 state that early discontinuation of overuse medications is the first line of management. Drug withdrawal. Drug withdrawal may be tapered withdrawal, which includes benzodiazepines, opioids, and barbiturates. In other cases, abrupt withdrawal is recommended with or without another medication to ameliorate withdrawal symptoms. Withdrawal symptoms. It may occur 1 to 2 weeks. Most common is an initial worsening of headache accompanied by nausea, vomiting, hypotension, tachycardia, sleep disturbance, restlessness, anxiety, and nervousness. Management of outpatients. First, we reduce or eliminate analgesic use. Reduce medication dose by 10% every 1 to 2 weeks. Immediate cessation is possible if there are no contraindications. NSAIDs in small doses such as naproxen 500 mg BID helps relieve residual pain occurring as analgesic use is reduced. Discontinuing analgesics is very difficult. Inform the patient that in some degree of pain is inevitable during this period. Second, introduce preventive medication. This is done once analgesic use is substantially reduced. It may also be given at the same time analgesic reduction is started. It must be emphasized that preventives often do not work in the presence of analgesic overuse. This is the most common cause of unresponsiveness to treatment. Management for inpatients. Some patients require hospitalization for detoxification. These are patients who have failed efforts at outpatient withdrawal or those with a significant medical condition such as diabetes mellitus or epilepsy that complicates withdrawal as an outpatient. Following admission, withdraw all acute medications completely on the first day if without contraindication. Clonidine is given for opioid withdrawal symptoms. Aspirin 1 gram IV is used for intolerable pain during waking hours. Intravenous chlorpromazine is helpful at night, but patients must be adequately hydrated. 3 to 5 days of admission is the period when the effect of withdrawn substance wears off. Here we give intravenous dihydropercotamine, which is given every 8 hours for 5 days. DHE induces significant remission that allows preventive treatment to be established. DHE may also be given with serotonin 5-HT3 receptor antagonist or neurokinin antagonist to prevent nausea. That's all. Thank you for listening.